Hi, good afternoon, everyone. This is Michael Ashton. I'm an infectious diseases physician in Bermuda and also chief of medicine at the Bermuda Hospitals Board. I am doing this for the first time on Facebook Live. I've already had a little bit of technical difficulty, but I'm hoping that this is coming across through the Patients First Bermuda group. And thank you for inviting me to talk about COVID-19 and our response in Bermuda. With that introduction, I'll just take the opportunity to just say that this is a fast-moving topic, and we've never been more informed as a society than we are now. So I know that the folks that would be listening to this video are likely very well informed already. There is, I think, a lot of opinion and anecdotes. So what I'll try to do is focus on facts where possible, and also try to provide some Bermuda-specific answers where possible as well too. So I'll take about 30 minutes and tackle some basic questions that I've received over the last 24 hours. And then I'll also just make some practical suggestions and perhaps touch upon the recent modeling that was published by the Bermuda government as well too. All right, and I'm getting feedback from some of the viewers that this is now online, so excellent. Second time around, more success. Okay, excellent. One of the questions that has been asked is just how deadly SARS-CoV-2 is. And this is surprisingly confusing because there are a number of different quotes out there, and it really depends on the methodology that's being used. I think a lot of the time folks are using case fatality rates, and those can be influenced by the sampling practices and also the number of cases that are reported. Probably a more reliable number is the infection fatality rate. And what this is it's the estimate of deaths among all infections. And so that number is probably around 1%. And in fact, there was a recent publication in The Lancet on the 30th of March, which is a good article for those that are interested, at 0.66%. This is probably 10 times more deadly than influenza based on that number alone. And again, I think it brings to our attention the fact that this is a disease that doesn't have any treatment as yet that's proven. So there are a number of test agents that are being studied, but none of these are proven as yet. Medications such as hydroxychloroquine, remdesivir, these are still being studied, and we are lacking the randomized controlled trials that are necessary to be able to recommend them as standard therapies. In the interim, we're relying really just on supportive therapy. Another question is really just about how contagious the virus is. Well, we can certainly say that the virus has been very successful in its spread. So it's gone around the globe. In less than 100 days, it's already in Bermuda, having gone all the way around from China. We consider this to be more contagious than influenza, and that's based on some of the R0 estimates. Some of you may be familiar with that. The other factor that's at play here, of course, is that no one has immunity to this virus, so it is much more rampant in its spread, and everyone is susceptible essentially to this virus. I'm going to move on to some other questions, and I will try to also field some questions from the internet live discussion as well too. This will be a little bit of a balancing act for me because I'm feeling like a little bit of a Luddite today. One question is how to protect myself. The advice from the government, the CDC, WHO, and Bermuda Hospitals Board are all consistent. with staying 6 feet away and physically distancing yourself, wearing a mask in public, and hygiene is, of course, paramount. Wiping down surfaces with effective disinfectants and avoiding sick people. There are a number of different disinfectants that are out there. There are studies that have also talked about how long the virus can remain viable on surfaces. New England Journal of Medicine article from a few weeks ago talked about plastic and metal having the virus viable for up to 3 days. Cardboard and probably other fabrics may be closer to 1 day, and then copper would have been a few hours at best. But nevertheless, wiping down surfaces on a regular basis can deactivate that virus quite quickly, because we know this is an RNA virus that's enveloped. If you disrupt the envelope, then you deactivate that virus. It can no longer cause disease. It needs human cells to transmit itself, and if it doesn't have human cells after a period of time, then it becomes non-viable. So in terms of those that are trying to protect themselves while working with sick people, at the hospital we talk about appropriate PPE for the risk, and that means a spectrum of PPE. It doesn't mean wearing a hazmat suit everywhere. It means for most social interactions, probably a cloth mask as per CDC is sufficient. And then as you move towards taking care of patients that are suspected to have COVID or are confirmed to have COVID, a surgical mask with eye protection, gown and gloves is appropriate. If you are doing aerosolizing procedures, which is such as intubation, putting a breathing tube down one's windpipe, etc., that requires an N95 or PAPR, which are the hoods that you'll see on television. The important point with all of these recommendations is that for the vast majority of cases, transmission of this virus has been through droplet and contact. And so we know this now with some confidence, because when we look at the cases that are being identified, they are all through close contact, and that can really only happen with droplet and contact modes of transmission. If we were seeing that the virus was being transmitted more distantly to folks down a hallway or in another room, then we would have to implicate airborne transmission as more common, and that's indeed not what's happening. Okay. So I may have repeated some of these questions but for the sake of being sure that the IT solutions have been solved, I've gone through those again. Some of the other questions that have come up are regarding practical things like groceries, and my family struggled with this as well too. I think that there's a risk of wiping down food with disinfectants. They shouldn't be ingested. And it's unlikely that you're going to have a significant amount of virus on those items. They should be unpacked. You should clean down the surfaces afterwards, wash your hands, and that should be sufficient. Again, we talked about the viability of the virus is limited, and it cannot replicate itself without human cells. One caveat, I think, is that colder conditions like a fridge may preserve the viability of the virus a little bit longer, but I think from a practical standpoint, that is really not a significant consideration. There was a question about delivery, and should I use delivery of food products and other things. I think there's probably some argument to say that that might be a good move in the sense that there's less footfall in stores, there's less physical exposures. It probably reduces the risk for everyone, but I would say that that risk is not quantifiable, and there's really too many variables to say anything more than that on that topic. So there's a question about if you're unwell and what to do. And I think it's important to realize that if you have a cough or fever at this time of the year, it's pretty much COVID-19. I think earlier in the year we could say that maybe it was influenza or rhinovirus, what have you. And in fact, there is a study that talked about co-infection rates with COVID earlier on in the year, and approximately 1 in 5 cases of COVID did actually have a co-infection, another virus that was at play as well too. But for the most part, I think if you have these symptoms, you have COVID-19 until proven otherwise. That's probably enough to make the diagnosis clinically. The testing can confirm the diagnosis, but your actions should be basically the same, irrespective of the test result. And if you have those symptoms, even if the test result came back negative, I'd be suspicious of that result. Now, most of the cases, as we all know, of COVID-19 are going to be mild 80% of the time. There is a online symptom checklist at bermudahospitals.bm. We'll see if we can post that for folks, and I think that's a useful checklist. It does include travel as part of the history, which I think is less relevant now that we've got community transmission at this point. So if you do develop symptoms, it's important to call your doctor and ask for advice in your specific situation. If you're feeling unwell, very unwell, then it's important to call the emergency department, and that number is 239-2009, and make your way there. There are some other support lines. The government line is 444-2498, and there's an emotional well-being helpline as well that's 543-1111. There has been some talk about what to do in terms of monitoring your oxygen levels. I think O2 monitors is an intriguing question, but I think for the vast majority of folks, it may be more difficult to interpret. These O2 monitors sometimes can give you false readings. But I think the message that can be taken home is that as soon as you become concerned about your symptoms, that contacting your doctor is important. We have had situations where folks have become short of breath quite quickly. Short of breath meaning you can't speak in full sentences without catching your breath, or even just some minor activity and you find yourself out of breath. Otherwise, in terms of managing this disease, it will be much like managing the flu. You should be monitoring your symptoms like we mentioned, and then also checking your temperature. A good investment is a good thermometer. I think that will go a long way. So in terms of how long will coronavirus be in Bermuda, I think it's safe to say that it's most likely here to stay. It will probably fall into the category of other viruses that were originally pandemic, such as H1N1. And that disease, even to this day, 11 years out, still causes severe disease and death. We expect that this coronavirus will circulate for the years to come. Our immune systems will become more familiar with it, so disease will likely be less severe. It probably mutates less than influenza, but I think that that's still a difficult thing to predict in terms of the behavior of a novel virus. I'm just going to check some of the comments here as best I can. And Jennifer, you talk about students returning to school. I'll touch upon that topic in just a little bit. And hi, Ben. That's very kind. Alrighty, okay, I'm going to keep on going then. So in terms of how long will we need to socially distance or physically distance, I think that, again, much like we expect this virus to be here to stay, I think some of those recommendations will be in place for the foreseeable future, unfortunately, at least until there's a herd immunity. and most likely for the rest of 2020 at least. I would say that the fall and winter of this year is going to be a dangerous time, and a lot of us are going to be anxious about it as potentially we resume some activities, and also as other viruses, winter viruses such as influenza, start to also do their part as well too, in addition to continuing to have to tackle COVID-19. It's arguable that some things will change for good, and so things like handshaking, coming to work sick, that will be really frowned upon. It is now, it should have been before, and most certainly will be in the future. And I think the need to be shielding our vulnerable will be important for the months to years to come as well too. If there's anything that good that comes out of this is, I think, a greater consciousness of the severity of some of these diseases. It's quite possible that we will encounter something like this in the coming years again. The reason that we are seeing this, I think, is partly because of the population density and also our proximity to animals as well too. Perhaps there's also some contribution in terms of the climate changes as well too, and the increase in vectors is probably a consideration for other pathogens as well too. So this is probably something that we're going to have to continue to consider for the weeks, months, and years to come. So next question is about how effective is testing in combating the disease. We should first talk about what testing is available. And the only validated test right now is PCR testing, which is the polymerase chain reaction nucleic acid amplification of the virus. That's the genetic material of the virus. We were able to genetically sequence this virus within a month of knowing about it, which is amazing. But it's been a whole lot harder to get out viral testing to the rest of the world. Bermuda finally, I think, is on the right foot in terms of its testing. But the important take-home point about testing is that it's a snapshot in time. It tells you whether the virus is present or not. And there are also concerns about false positives and false negatives. You could also test negative at the beginning of the day, become viremic, and start shedding the virus, and then hours to days later you can turn positive. So it has to be interpreted in the context of those limitations. As it is right now, we don't have validated antibody testing, which would give us an idea about the levels of neutralizing antibodies, i.e. Whether our immune system has recognized the virus and also appropriately responded to the extent that it could protect us from future exposures. That should be forthcoming, but there are some major concerns that we're seeing with these tests in terms of their validity, and a bad test is worse than having no test at all, frankly. And so in terms of the future of that, I'm hopeful that that will give us some guidance in terms of when we might be able to safely have certain folks return to something closer to normal. But right now, there are a lot of limitations. Other limitations included in this are, trying to design a test that will still discriminate this COVID-19 coronavirus from all the other coronaviruses that you are likely already exposed to. So it has to be able to discriminate between that, and it can't just detect antibodies, it has to detect antibodies that are protective as well too. So this will take some more time, and in the meantime we will have to rely on the PCR testing. And I'll get to the PCR testing a little bit more as it relates to modeling in just a little bit. I might just take a pause here and talk about, I'll just answer very briefly a question about the vaccine. I think, unfortunately, as many of us have heard, vaccine will take many months and probably not until next year to be developed. There are a number of candidates that are being looked at. and they're all focused on a particular aspect of the envelope, the spike antigen. That may or may not be the right target. And I think first you have to show that it's safe. You have to show that it's not going to enhance the immune response in a way that actually could make you sicker from the virus or sensitize you to the virus. And then we have to be sure that it's going to have a lasting effect as well too. And in fact, we don't know a whole lot about the duration of immunity that's gained naturally from the wild type virus infection as well too. So there's still a lot to be learned there. And in the hospital setting, I can tell you that this is not something that we are counting on in terms of our risk management and modeling. There's a question about recommendations on tourist return to Bermuda. And I sort of approach this question carefully because it is such an important aspect of our country's well-being. Unfortunately, I think we're going to have to be very careful about opening up the borders for tourism. Quarantine's probably not going to be practical for most of our tourists. I just mentioned that PCR testing is only a snapshot in time, so you could test, the result might be negative, and then someone becomes positive subsequently. Thus far, the immunity testing is still not validated. That ultimately, I think, would be one of the criteria that we could use if we could show that there was immunity to the virus. That would increase our confidence in the safety of opening up the borders. Also, if we had effective treatments, we have no proven effective treatments at this time. Treatments that could be used to treat and also to prevent would be consideration as well too. Those that are familiar with malaria prophylaxis or prevention, that's an example of treatment as prevention. And so there are medicines that you can take that actually prevent the transmission of pathogens, and it would be great if we could find something like that for this virus. Of course, a vaccine would be the best scenario. In the meantime, the worldwide natural response is to gain herd immunity through exposure, but this, of course, comes at a cost. So there was a question about who is more contagious, symptomatic or asymptomatic folks. I will just add also that there's another category there called pre-symptomatic. So those are patients that don't have symptoms at the time, but they are about to develop disease. So in many cases, patients won't develop symptoms for several days. And we know that in some cases, one can become infectious up to 3 days before symptoms actually develop. And that's a very challenging aspect of this virus. An example of how much asymptomatic transmission probably happens can be seen from the Diamond Princess example, where almost half of those that were tested positive had no symptoms at all. And that was an early red flag to a lot of us, that there was something very unique about this virus that was going to make it extremely difficult for us to eradicate it and contain it. And that's indeed what I think is happening here. Unlike influenza, where you will develop symptoms and you may be infectious for, say, a day before the symptoms, COVID-19, I think that there are some reports that suggest that it could be a few days that you're actually contagious before you develop symptoms. And then to add to that, on the other side of the infection, once you clear the infection, there may also be shedding of the virus for many days afterwards. In fact, there's documentation of 37 days or longer of shedding. Now, it's unclear whether that virus that's being shed is actually viable and can cause infection. That still needs to be determined. But a test result might very well come up positive many days after the virus has otherwise been cleared clinically. What I can say is that for most infections, if you are symptomatic, i.e. you have fevers, you are more likely to have more of the virus. So the more symptoms, the more severe the symptoms, more likely that you have high viral loads. Typically, as the fever defervesces, typically you'll start to see an antibody rise. That's usually the immune humoral response is now taking control of the virus, and so the the levels go down and the antibodies go up. But every patient is different, and so in Bermuda we've advised to at least give 14 days from onset of symptoms or 3 days after resolution of symptoms, whichever is longer, and that's a longer period of time than the CDC even says. We've taken a more conservative approach here. People have asked why, and it's really because of this uncertainty. And if we're going to give a blanket recommendation, I feel more comfortable saying that it should be a longer period of time that we are advising folks to isolate themselves. And in fact, it really should require the physician input as well to guide patients in terms of their particular course. I mean, the bottom line is that the virus is not looking at a calendar, so it has to be interpreted, the safety of stopping isolation has to be interpreted in the context of each patient and their immune system. Well, that's probably enough said on that topic. So how effective is testing to combat disease? I've already mostly talked about this. There's only the validated PCR testing that's reliable at this time. Testing is still an important tool. And the reason I say that is because if a virus is contagious without symptoms, you really have no other way of knowing except maybe some epidemiologic information, but that will be very weak information. And so when you have a virus that's contagious without symptoms, testing has an important role to play. But it's still, even in Bermuda right now, it's a limited resource. It's a snapshot in time. There are, like I said, there's false positives and false negatives. If you are familiar with the testing process of collecting a specimen, this goes at least 7 centimeters to the posterior nasopharynx. That's right in the back of your throat, horizontally, not upwards. And not every swab is going to get the virus. It's going to pick up the virus. Once it's on the swab, I think there's more confidence in the ability of the testing to be able to replicate that virus. I think that the testing phenomenon is very sensitive and quite specific based on the probes that they're using. But probably the collection of the specimen is where we have a weak factor. All right, so I think another important rule about testing as a tool for combating disease is that if you test, this is what we teach all of our medical students, it should only be done if the result is going to change what you do. And so the test will be best used if it's targeted. There's little sense in testing someone who is low risk and low probability for the most part. It's best to be testing, therefore, symptomatic folks and those around the positive test results, and then isolating and quarantining accordingly. There may be a secondary role if testing is available for high-risk populations, such as the essential workers, but that is on the basis of having an abundance of tests in the system. And of course, recognizing the limitations of the test results and not relying on it as a false sense of security. And so, Annie, you write here, advice for essential workers and how far should they be to their own families when they come back. This is a really challenging one for myself. And I think that this is a bit of a personal decision, but we have this conversation with our healthcare workers a lot. Thus far at the hospital, there have not been any documented cases of nosocomial or in-hospital transmission of the virus. I believe that the reason for that is our aggressive universal testing that we're doing currently, our presumption of a positive case until proven negative, and then continued close monitoring. In addition to that, I think that the PPE is working. It's very effective if it's used and folks are trained appropriately on it. And so if you use the right PPE for the right risk, you will be protected as a healthcare worker. Nevertheless, when I come home, I presume that my clothing may be contaminated just from surface contact with other surfaces, whether it be a desk or a telephone or what have you. So I personally change my clothes before I hug my kids. Shoes are contaminated, probably with a whole lot more than just a virus as well too. But if you are following the appropriate PPE and there's been no breaches and you take a common sense approach to this, then it is safe to hug your kids after that, in my opinion. And then there's a question about if you were to test positive and no symptoms, well, a test, if it comes back positive, that's a diagnosis. And so you would have to be treated accordingly. So that is not quarantine, that's isolation. And in those scenarios, if it cannot be done safely in one's home because of vulnerable populations, then there has to be a conversation with the physician and the employee health physician to come up with a safe solution. All right, I'm going to just go back to some of the other questions, and I'm sensitive of the time, but I figure people can come in and out, and they can either listen or not. So hopefully this is of some benefit for folks, and I'll just carry on with some of the other questions here. There's a question about comparison to bird and swine flu. Well, those are different viruses. This COVID-19 is not influenza. I guess there are some similarities because all of these come from animals, i.e. they're zoonoses, and their novelty is also a big factor in the spread of the viruses because the population that's exposed would be presumably not immune and thus susceptible to the virus. But that would be probably the extent of a comparison that I would make with those. And in terms of why this happened, could it happen again? Why such a grand scale? I think I talked about that already in terms of the population density and proximity to animals. The only way that this is not going to happen again is if the world population changes or human behavior changes or both. And working with people, I know how difficult it is to change people. So I think it would be better, well, we try to mitigate the risk, but it would be, I think, going forward, important for us to be talking as nations and peoples about how can we never let this catch us off guard again, and what are some of the plans that really should be in place. We had a pandemic influenza plan, a novel coronavirus plan. All of these were several years ago that we wrote these. Just like any hospital, we had these. But I think now people are listening a little bit more closely, and going forward, we're going to have to be sure that they continue to be updated and communicated in terms of the seriousness of the risk. All right, so life after lockdown was a question. Well, I think in the immediate sense, because this I think is a relevant question for Bermuda, what will we do after the current 4-week period of lockdown? And I've communicated as best as I can to the leadership of our country that physical distancing will need to continue. I believe that everyone is on the same page on that. I think universal masking will need to continue for the time being. We will need to either have herd immunity or an effective treatment. We're not holding out for a vaccine, as I mentioned. I think that for the foreseeable future, the borders will need to be restricted, and if you do come through, you need to be asked to quarantine for that 14-day period, which is an important number. even by 12 days, the vast majority of cases will become picked up. By 14 days, statistically, it's extremely unlikely that you would have a transmissible virus if you are asymptomatic and otherwise healthy. So I think that there's arguably some things that should change for good, and already mentioned that before. Things like handshaking, coming to work sick, shielding the vulnerable. These are things that going forward we should continue to consider those as long-term changes. I'll touch very quickly. Well, it may take a little bit more time in terms of the safety of opening schools. This is, I think, a very difficult question that we are grappling with right now. The schools are now doing all of their studies away from campus. That's compromising their education, I believe. It's also a very significant strain on families, and it certainly does not feel like business as usual. But I think you have to ask first, can young people get the virus? And the answer is clearly yes. Can young people get serious disease? Rarely, but yes. Can people who are young transmit the virus to others? Most definitely yes. Is a school a large gathering? Without major modifications, it is. So I think that there is a significant risk at this time to opening schools. And is this the right time? Likely not. And the reason in Bermuda that I say that is that we currently are experiencing 2 large outbreaks in nursing homes. One of the nursing homes, that outbreak is yet to really reveal itself in terms of the implications of it. We know that it will probably be a couple of weeks before we see the true impact of that outbreak in terms of severe disease, hospitalizations, and deaths. So even though right now, knock on wood, we have a pause in the number of cases, and I do believe that right now we have flattened the curve, and we can talk more about that with regards to modeling. To aggressively change our restrictions would be unwise, to say the least, because there is still more difficulty to come. So an advisable method, I think, would be to be monitoring the impact of various changes, such as the nursing home outbreaks, opening of the lockdown with limited restriction lifting, and seeing how that impacts our disease incidence on the curve, and recognizing that we're going to have to wait a couple of weeks at least after every intervention before we can say that we truly know the impact of each of those interventions. And certainly if we were to move from a lockdown phase to a restricted social distancing phase, it would be important to likely monitor the incidence for 2 incubation periods or 28 days to really get an understanding of what those impacts are. And furthermore, if we see that there's a rise in incidence, we need to be prepared mentally to reinstate the lockdown. It is quite possible, and many countries are looking at this as a contingency, that we will relax the lockdown and then potentially need to reinstate it if we see too high a rise in incidence. And I can give some guidance in terms of specific numbers, at least with regards to the hospital and what we can accommodate from our capacity standpoint. So that probably gets us to modeling, and I'll just take a quick look at some of the questions here. Yeah, possibility of virus entering before active screening. Miriam, I think that it is possible, and certainly those questions have been asked before. Some patients that I've talked to just swear that, in December they had the absolute worst respiratory syndrome, and it felt very much like COVID-19. I suppose it's plausible. Probably the only thing that is going against that is that at that time, in December, January, February, we were not seeing any unexplained severe pneumonias and deaths in the hospital setting here. And we monitor every death at this point, and we had up until just this COVID phenomenon monitored every single death in the healthcare system to be looking exactly for things like that, unexplained deaths, or if there was something we could have done differently. So we were watching closely, and we did not see anything like that. We were already at that point aware that there was COVID-19 circulating elsewhere in the world, and so it was also on our minds as well too. So I think realistically it's very unlikely, although anything is possible. Certainly at this point we can say that unfortunately we have local transmission of the virus, the question in my mind is now, what phase of response are we really in? Are we still in a containment phase, or are we in a mitigation phase? What I think we can say is that we're seeing a linear curve when it comes to incidence of cases of the virus, as opposed to an exponential curve. And that's very reassuring, and it's thanks to all of the hard work and sacrifices of the community in terms of the lockdown and restrictions in one's freedom that has had a positive effect on this and allowed us to have that linear curve. We've had 5 deaths, very sad, and we expect more deaths. We have patients in the ICU right now. Each of those patients has a 40% mortality rate, essentially. But certainly we're in a better spot than we ever would have been if we hadn't implemented these measures. Again, a sincere thank you to everyone for making those sacrifices. I'll get to the modeling that was released by the government just recently, and just talk about some of the key takeaways. And I think there's a mention to do it briefly. That might be hard for me to do. But I'll do my best here. I want to just make it clear that I'm not directly involved with the modeling. I was familiar with it. I've seen it. I've seen the assumptions that are included in it, and I would say that they are reasonable assumptions. I won't get into the details of that, but they are published. The Royal Gazette has them as well too, so you can look through them. But I think they're reasonably good assumptions for Bermuda, and fortunately I think that what you will see is that we are probably following the better case curve right now. Most people will be alarmed by the worst case curve, and I think that at this point we are following more likely the better case curve. There is no best case curve, unfortunately, but we'll need to continue to trend this out because it's still very early in the pandemic for us. In terms of how could the hospital cope with the worst case scenario, there's absolutely no way that the hospital could cope with it. That is very much clear. We would be quickly overwhelmed as a community hospital, and with that would come unnecessary suffering and death. So the worst case scenario is something that we cannot accept. And the hospital would very quickly be overwhelmed. And what I'll say, in fact, even with the better case scenario, where we have at the peak, say 16 hospitalizations per day, that will be a difficult time for Bermuda and for BHB. There is a useful capacity tool that was published in the Annals of Internal Medicine on the 16th of April. If you plug in some numbers to that, it's for those that are interested. For example, we say that our average length of stay is 11 days. That's actually pretty good. Sometimes we're longer than that. If we say we have 120 beds that are dedicated to COVID-19, which means really focusing almost 100% on just COVID-19, and having 20 beds with ventilators, which is about where we're at, we would have ultimately a steady state of bed turnover. That is, once the capacity is reached, of about 12 beds, i.e. we could accommodate 12 new cases per day. There would be a period of time where actually we would be falling behind and at risk of being overwhelmed. But I believe that cautiously being optimistic that BHB will be able to keep pace with the demand if we are able to continue with the better case scenario that's modeled. Of course, these models are just that. They depend on the assumptions that are put in place. I think they still need to be revised on a regular basis. We need to be looking at our own R0 calculations. We need to be setting certain criteria, such as, for example, if we start getting at the hospital more than 4 to 5 new cases daily of COVID-19 being hospitalized, that would be probably a red flag to say, hold on, we're at risk of getting overwhelmed shortly, and to then reenact some of the restrictions that have been at play. So that would be some general guidance that I would offer to the island. Last thoughts. I think I'm just going to close things up. It's been well more than I was expecting to spend on this. I'll just say that we're fooling ourselves if we think we're in full control of this virus. We're only partly in control of it. This can be a humbling experience, but our situation is far better than it would have been if we hadn't made the interventions that we made. We need to be mentally prepared for continued restrictions intermittently, possibly further lockdowns, if the data supports it. And most importantly, because of how difficult this time is, we need to be kind and forgiving to each other. And again, it's an important reminder of focusing on the things that are most important in our lives. So I think with that, I'm going to close, and hopefully this even was recorded. I don't even know if it really got recorded, but hopefully I'll hit the finish here and it'll get posted. So best wishes to everyone, and peace and love.